Well, listen, everybody, it's 2 minutes past, so I'm going to suggest we start, if that is all right. A very warm welcome.
Emily's just joining us.
Oh, welcome, Emily. Hello. Hi. And welcome, Sophia. Feel free to say hello to each other in the chat. It's very nice to see you all. A warm welcome to our third NASP International Evidence Collaborative webinar. We've got some great talks for you coming up. I'm Helen Chatterjee. I'm one of the co-leads for the NASP Evidence Collaborative, along with the wonderful Dr. Marie Polley, who's here today as well.
Hello,
and
everyone.
Other folks like the lovely Kerrin, who is here, having a cup of tea, and Helen Seers, who you're going to be hearing from soon as well. So a very warm welcome to everybody. So the format for today is we've got two fantastic talks for you. We're going to start off with Caitlin Muhl. She's going to be talking to us about how they're defining the social prescribing work that they're doing. She's based at Queen's University in Ontario. So we're going to have hear from Caitlin first off. Then there'll be some time after Caitlin has given her talk to ask some questions. And you can feel free to post questions in chat, or I'll invite you to turn on your cameras and your microphones to ask your questions. So please start thinking of questions as Caitlin's giving her brilliant talk. And then at about 25 past, half past, we'll then move into our second presentation from Helen Seers and Marie Polley, talking about the work that the International Evidence Collaborative has been doing on behalf of NASP and international for independent age around older people and poverty. And the same format. You'll hear from those guys for about 15 minutes, and then there'll be some time at the end to ask some questions. And Emily's joining us here from Independent Age, so hopefully she can address any questions you might have, in particular about perhaps their interest in commissioning this sort of work. So I hope that all sounds okay for format. I've mentioned that we're being recorded. I hope that sounds all right. We're going to, Sonia from the Social Prescribing Network, who are our hosts for today, are going to put in the chat details of how you can sign up for the International Evidence Collaborative. We're going to be hosting some more webinars over the coming months. So that would be a good way to find out about upcoming webinars. And the webinars are a great way, obviously, to learn about the work that other people are doing. So if you're interested in contributing, then please get in contact with Marie or I, and we'd love to hear from you. So if that all sounds all right, I'm going to, without further ado, invite Caitlin to start sharing her screen and hand over the mic to you, Caitlin.
Perfect. Thank you so much.
Thank you.
So hopefully we can get that to work properly. All right. Now, can everybody see that okay? Is that looking all right?
Yeah, it's good.
That's good. Okay, wonderful. And let me know if my sound is not good at all throughout, but hopefully no technical difficulties. So hello, everyone. My name is Caitlin, and I'm super excited to be here today to talk to you about a really important aspect of social prescribing, which is how we define it. So let's jump right into it, get right to it. So there's growing interest in social prescribing across the globe, with over 20 countries involved in the social prescribing movement. And yet here is an excerpt from a recent article on social prescribing. But what is social prescribing? There is no clearly agreed definition. Now, this is just astounding to me. We have this incredible momentum around social prescribing globally, and yet we can't agree on how to define it. The fact that there is no agreed definition of social prescribing is something that is constantly highlighted in the social prescribing literature. And these examples here are just the ones that I could fit on the slide, by the way, so there's many more. Looking at the social prescribing literature, it seems what we do agree on about the definition of social prescribing is the fact that there is no agreement on the definition of social prescribing. So all of this caught my attention a while back. But what really concerned me was what the social prescribing community was saying about the implications of not having an agreed definition. So I'll turn your attention to the bottom two statements. The one on the left, we'll look at that first. So the author stated that there's no agreed definition of social prescribing, and as such, the concept is considered nebulous and open to different interpretations. And then another author on the right, after reviewing the social prescribing literature and realizing that the definition varied significantly, and that many studies didn't even provide a definition, stated that the use of common language is the crux of developing a common understanding and it is therefore worth striving for common terminology and definitions in social prescribing. So I realized that the lack of an agreed definition of social prescribing was a huge problem, and I thought to myself, why don't I try to address this problem? Now, I found out very quickly that the solution to this problem was not going to be as simple as developing an agreed definition of social prescribing. And that's because there are actually two different types of definitions. There's a conceptual definition, which tells you what a concept means, and an operational definition, which tells you how to measure a concept. So what this means is that both conceptual and operational definitions of social prescribing were needed. So that's what I set out to do. So the aim of this study was to develop internationally accepted conceptual and operational definitions of social prescribing. So a Delphi study was conducted with an international multidisciplinary panel of experts. Now, you might be wondering, Caitlin, what's a Delphi study? Well, the Delphi technique is a method of gaining consensus on a particular topic through multiple rounds of questioning of experts in the field who remain anonymous and receive feedback between each round. So this study leveraged the expertise of social prescribing experts, and it did so in a way that limited bias in the process of achieving consensus. So I'll share a few quick details about the study with you. The study took place between June and September of 2022. And before the study began, we set the bar for consensus at 80% agreement, which just means that at least 80% of the expert panel had to agree for us to be able to say that there was agreement. Now, there's actually no rule for what this percentage should be for Delphi studies. So we decided to set the bar high at 80% because we really wanted to be confident in the outputs of this work. And the study was conducted online through an online survey platform that is specifically designed for Delphi studies. Now, this is my favorite slide in the whole presentation. There were 48 social prescribing experts in this study who represented 26 different countries across 5 continents. In Asia, this includes China, Japan, Singapore, South Korea, and Taiwan. In Europe, this includes Austria, Bosnia and Herzegovina, the Czech Republic, Denmark, England, Finland, Germany, Ireland, the Netherlands, Northern Ireland, Portugal, Scotland, Spain, Sweden, and Wales. In North America, this includes Canada and the United States. In Oceania, this includes Australia and New Zealand. And in South America, this includes Brazil and Ecuador. And I also want to mention that the experts in this study represented many different expert groups, including the Global Social Prescribing Alliance, the National Academy for Social Prescribing, the Social Prescribing Network, the Social Prescribing Youth Network, the Canadian Institute for Social Prescribing, students that are involved in national social prescribing student groups, authors of academic and gray literature on social prescribing, and others involved in social prescribing, including researchers, healthcare providers, link workers, healthcare administrators and managers, and even a patient. So the study consisted of 3 rounds, and after the 3rd round, consensus was achieved on the conceptual and operational definitions of social prescribing. And I do want to mention that the conceptual definition includes long and short versions. So I'm going to share all 3 with you now. I will share the short version of the conceptual definition, the long version, and then the operational definition. All right. So we have the short version of the conceptual definition here. Social prescribing is a means for trusted individuals in clinical and community settings to identify that a person has non-medical health-related social needs and to subsequently connect them to non-clinical supports and services within the community by co-producing a social prescription, a non-medical prescription, to improve health and well-being and to strengthen community connections. So that's the short version, and you'll find actually that it's embedded in the long version. So I'll get to this now, and I won't be able to say this all in one breath. Social prescribing is a holistic, person-centered, and community-based approach to health and well-being that bridges the gap between clinical and non-clinical supports and services. By drawing on the central tenets of health promotion and disease prevention, it offers a way to mitigate the impacts of adverse social determinants of health and health inequities by addressing non-medical health-related social needs. For example, issues with housing, food, employment, income, social support. While it looks different across the globe, it is recognized as being a means for trusted individuals in clinical and community settings to identify that a person has non-medical health-related social needs and to subsequently connect them to non-clinical supports and services within the community by co-producing a social prescription, a non-medical prescription to improve health and well-being and to strengthen community connections. It requires collective action and collaboration among multiple sectors and stakeholders. It begins with an identifier, usually a clinical professional, who identifies that a person has non-medical health-related social needs. Typically, they refer the person to a connector, but they may act as the connecting agent themselves by connecting the person to non-clinical supports and services within the community. Hence, either party may co-produce the social prescription with the person. The connector, who is usually a non-clinical professional, provides personalized support and focuses on what matters to the person. They co-produce a personalized action plan with the person by supporting them to assess their needs, strengths, and interests, and they subsequently connect the person to non-clinical supports and services within the community, support them to access those community resources by addressing any barriers that may exist, and follow up with them. Through a feedback loop, they report back to the identifier. They conduct motivational interviewing to promote behavior change, spend time with the person to build trust, and empower them to take greater control of their own health and well-being. Finally, monitoring and evaluation are conducted to measure outcomes through the collection of qualitative and quantitative data and the completion of pre- and post-assessments to understand the impact on the person, for example, their non-medical health-related social needs, health and well-being, physical, mental, and social, satisfaction, clinical and non-clinical supports and services, for example, demand and costs, and the community. So that is the long version of the conceptual definition, and this is the operational definition, which looks a bit more like a recipe or a math equation. Social prescribing is a holistic, person-centered, and community-based approach to health and well-being that satisfies condition 1 and either condition 2 or conditions 3 and 4. So what this means is in order for something to be social prescribing, it must satisfy condition 1 and 2 or conditions 1, 3, and 4. So condition 1, identifier identifies that person has non-medical health-related social needs, for example, issues with housing, food, employment, income, social support. Condition 2, identifier connects person to non-clinical supports and services within the community by co-producing a non-medical prescription. Condition 3, identifier refers person to connector. Condition 4, connector connects person to non-clinical supports and services within the community by co-producing a non-medical prescription. So that is the operational definition, and all of the definitions have been transformed into the common understanding of social prescribing conceptual framework, which is otherwise known as the CUSP framework, and was named to reflect the potential of this work to bring about a point of transition in the social prescribing movement by advancing common understanding. So, next slide might take a moment to load. There it is. So bringing everything together, the conceptual definitions, the operational definition, and the CUSP conceptual framework, we now have the ability to answer the question that I had on my first slide. What exactly is social prescribing? So social prescribing involves trusted individuals in clinical and community settings. And there's an identifier, and they identify that a person has non-medical health-related social needs. And this may be a clinical professional, but this isn't always the case. Now, this is by no means an exhaustive list that I have here, but in terms of the need, this may include issues with housing, food, employment, income, or social support, such as social isolation and loneliness. Now, the identifier may be the one who connects the person to non-clinical supports and services within the community. Again, this is by no means an exhaustive list, but this may include supports for basic needs like income, food, and housing, professional skills development programs, opportunities to engage in physical activity like exercise classes, team sports, and individual sports, support groups, arts and culture programs like music, theater, and painting, opportunities to experience the giver's glow through volunteering, social activities like book clubs, chess clubs, and knitting groups, and opportunities to connect with nature. Now, more frequently, the identifier refers the person to a connector. And again, this may be a non-clinical professional, but this isn't always the case. And in this case, the connector is the one who connects the person to non-clinical supports and services within the community. And what is important to note here is that this is where the co-production of the social prescription, the non-medical prescription, occurs. So there you have it, social prescribing in a nutshell. Now, we're currently in the process of publishing this work, but the preprint is available online, so you can read the manuscript while we're in the process of publishing it. You just go to this webpage here and then click on either full text or download PDF, and I can put that link in the chat for you later. And I quickly want to highlight the following excerpt from the manuscript. So we say, for the first time in the history of the social prescribing movement, we now have internationally accepted conceptual and operational definitions of social prescribing. In addition, the conceptual definitions are distinct from pre-existing definitions, and to our knowledge, the operational definition is the first in the world. The definitions are flexible yet concrete. They recognize that social prescribing looks different around the world and account for the nuances, but at the same time, they outline the structural components of social prescribing that are shared across the globe. So I can't get into the details, but if you're interested in learning more about how they're distinct from other definitions or why they're important and build on the literature, definitely check out the manuscript. And quickly, I'll go over this. You might be wondering, how might I use the outputs of this work? So in terms of the conceptual definitions, these are the ones where it might be useful to simply define social prescribing in your work. That's the kind of your basic dictionary definition. So that's where it might be useful. And I'll show you a great example of how this was done in a recent report on the next slide. In terms of the operational definition, you may want to use this definition to determine whether a policy or initiative meets the criteria for social prescribing. And if you're conducting evidence synthesis, you may want to use this definition to develop inclusion and exclusion criteria. And in terms of the framework, you may want to use this framework as a guide in efforts to implement and evaluate social prescribing initiatives and policies. It may be useful to situate social prescribing initiatives and policies within this framework to ensure alignment with current understanding of this concept and to embrace a common and comparable approach. And if you are conducting evidence synthesis, you may want to use this framework to map the evidence base and to understand where knowledge gaps exist. So there are several examples of ways in which people are already using the outputs of this work, but I only have time to share one with you today, which is this report on social prescribing around the world that was just published by Kahn et al. In partnership with the Global Social Prescribing Alliance, the World Health Organization, and the National Academy for Social Prescribing. And I'll put the link in the chat for you later as well if you haven't had a chance to look at it yet. It's wonderful. So right at the start of the report, the authors set the stage by using the short version of the conceptual definition to define social prescribing before diving into case studies of social prescribing around the world. And the last thing I want to highlight is how this work is already kind of shifting the narrative in the social prescribing literature. Now, it's probably too tiny to read, but I'll read it for you, so don't worry. If you look at the title of this page in the report, what is social prescribing? This should remind you of the first slide of my presentation, where the answer to this question was always that there is no clearly agreed definition of social prescribing. Well, for the first time ever, we're now seeing a transformation of the response to this question, with the authors of this report stating the following. Historically, the lack of a universally accepted definition of social prescribing and its necessary dependency on local contexts has created heterogeneity in its implementation and practice. However, a recent Delphi study was conducted to develop a global definition of social prescribing, gaining consensus from its international multidisciplinary panel of experts. Now, I don't know about you, but I think that's a pretty exciting step forward for the social prescribing movement. So these are the references from today, and that's all. So thanks so much for listening. Happy to answer any questions that you might have.
Great stuff. Thank you so much, Caitlin. And what a fantastic insight into that really rigorous process that you've been through. Really, really fantastic work. Congratulations. So questions, comments, ideas for Caitlin? Don't be shy. Feel free to ping up your hands or heckle at me through your microphones. Can't see any hands so far. Any?
Charlotte's got
Questions?
her hands up.
Oh, go for it, Charlotte.
Yeah.
Hi.
And maybe you could introduce yourself, Charlotte.
Yes, so I'm Charlotte Osborne-Ford, and from 1st of April, I will be the new CEO at the National Academy of Social Prescribing. So really nice to see everyone here today, and hopefully I'll get to meet more of you shortly. It's just a fabulous piece of work. I can see it's really groundbreaking and it's really transformative. So just many congratulations. I did have one question, which was about one of the sort of conditions or part, which was quite focused on need. So the trusted person sort of identifying that there's a non-medical need. And I just wondered whether there was any feedback from the experts or as part of the process around a more sort of salutogenic process, because actually if we look at social prescribing as about building health, then it can be beneficial for people that are already in good health but just want to continue to build and to be in the best health possible. So was there much debate about this sort of perhaps deficit model of need or of issue compared to social prescribing being a potentially universal service that could even improve the lives and build the health of people that are already satisfied with their health? Thanks.
Really interesting question.
Yeah, that's a great point. Thank you so much. I would say, no, there wasn't that sense yet. The general, really, the consensus was that there's some sort of non-medical need. What I'd be really interested to see is the shift over time. Like if this same study was done in 5 or 10 years from now, maybe we would find that, right? Like with signposting, I find, for example, like 5-10 years ago, that was kind of grouped into social prescribing. But with this study, I found the experts were like, nope, that's not the same anymore. That's totally different. We've decided that's different. So I would be very interested to see if somebody did the same thing. And I hope someone does in 5 or 10 years, if that is what we kind of shift towards for the definition. Thank you.
Thanks for your question, Charlotte. And thanks, Caitlin. Next up, we've got Elizabeth and then Cora.
Hi, thank you. Like Charlotte said, that was such a helpful presentation, and this is going to be such a useful piece of work. Thank you so much for Caitlin for grappling with it all. I think that's probably what everybody's thinking. And to have the whole thing, the operational definition as well, is just so practical. What crossed my mind, and obviously I haven't read your paper yet, so you perhaps discuss this in your paper in more detail. You mentioned the needs, and you made a passing comment of I might not have included them all. And what just crossed my mind is looking at definitions of determinants of well-being, social determinants of health, and categorizing those as social, economic, environmental, cultural, those groups. Would that help to conceptualize the definition of need and help also to make social prescribing schemes more operationally systematic in their coverage of things that are left out of them, like green social prescribing? What do you think? Is that a useful way to go forward? Because it might be something that I start to look at myself.
Yeah, I want to make sure I understand your question fully. So just thinking more so about creating a framework for the different needs that might exist for social prescribing. Is that kind of how I'm understanding it?
Yes, and I think in part the way Charlotte was approaching it as well, that these are all the social determinants of health, and we might actually be accessing some of them really well, or having a capability to function in some areas better than others. That maybe it could be combined with a capabilities approach, moving slightly away from a deficit model. It's all just vague thoughts, and I haven't really explored them. I can see a few people nodding. I don't know whether that's a useful area for me to look more closely at. Or there's probably already other work going on in that field, obviously.
Yeah, there absolutely might be, but you're very right that this is so closely tied to the social determinants, right? So all the needs that were, brought forward as examples, all of them are listed as social determinants. So yeah, that would be where I would turn to think about all of the different needs right now when we think of why somebody might receive a social prescription. But again, maybe in the future it'll broaden, right? And maybe it will just be for some sort of non-medical need, but for everybody.
Mm-hmm. Okay, thank you.
Thanks, Elizabeth. We've got Cora next.
Hi, here from the United States. And this is just so exciting and interesting. I kind of got introduced to this through the University of Florida's Arts and Health Institute. And it's interesting. I feel like what I'm thinking of kind of follows the last two speakers. I work with people with disabilities and have used the arts as a way to kind of help bridge people from the transition from therapy, rehabilitation into the community. So this is so in alignment with, in a sense, what I've been trying to do informally. But I often find that somehow that people with autism, people with disabilities are a little bit left out of the conversation. We look at chronic illnesses like diabetes and those kind of things, but so I guess I'm just thinking that but it relates so much to what health is, you know, in a holistic way instead of just, you know, kind of taking care of diseases. So that notion people have been bringing of looking at really the social determinants of health in a very broad sense, in the sense of the human sense. It's not really a question that I have, but just kind of trying to understand how this fits, how all of this begins to work towards this completely more holistic sense of what health is and how it's supported through many avenues in our communities. But that's really all I have. It's not really a question.
No, thank you so much for your comment. And one thing I want to make sure is that you're connected into Social Prescribing USA, because that's a group that just started. So if you're not, I'll put that link in the chat as well.
That's
once
great.
I'm done.
Yeah,
So.
I think it's a long way off to be formally here. But also I think there was a question in the chat about, I think there are ways in which other cultures use this kind of approach in a kind of organic way. Our indigenous cultures here in the United States, you know, that I don't know, it just needs to be valued and looked at and maybe provide a lot of guidance.
Yeah, that's a really good point, Corinne. And I think that, I guess a question from that might be around how people with lived experience and participants and recipients of who've been involved in social prescribing were involved in the research, Caitlin.
Yes. So we did have a patient involved. I would have liked to have more patients, but that's a difficult group that I found to get involved in the work. But we did have one, so I was really grateful for that. And like I mentioned on that other slide, good diversity of different expert groups as well, right? Which was really nice. So
great, thank you. And Marie's got a question.
Yeah, and it's kind of like a comment, sort of following up on what Elizabeth was saying, actually. So Helen and I use Michael, which asks people what their concerns and problems are. So we already have a framework of about 30 odd categories of things that people say in social prescribing. So this is, you know, this is what I want sorting out. So that could be transport, it could be isolation, it could be stuff to do with employment. So we've captured that as a starting framework. And we've been using this approach for nearly 20 years now. So we've got these frameworks in various different cohorts of people that are trying to get their needs met through a medical system, but their needs are not medical. But interestingly, some of the needs are medical. So, you know, these people have seen a medical practitioner who sent them to a link worker, and they're having social prescribing, and the social prescriber is identifying they've got unmet medical needs. So there's a whole anathema there, isn't there, of why did they have to go to a link worker to have their unmet medical clinical needs identified to go back. But so there is already work and frameworks that we've done which just uses the person's voice and only the person's voice. And I think there's a good point about people with disabilities, neurodiversity, you know, not having a seat at the table really, or their voice really being represented, because, you know, they don't work and communicate in a way that we've designed our social settings. So often we're not even asking them in a way that's appropriate for them to have their voice. But anyway, so I'm going to stop there. But
Thanks,
I just think there's some really interesting conversations. And yes, Cora, if you want us to introduce you to Dan and Nicola in San Francisco, who are sort of leading, then I'm happily, if you send us your, I think we've got your email, I'll make an introduction for you. So be very happy to do that. Thanks, Helen.
Marie. We've got time for one more question, and I think, Cunley, you've got your hand up. We can't see you, perhaps because you're still out and about in Manchester, but do you want to turn on your mic and ask your question? Welcome to Cunley. He's a a digital artist from Africa and working as a global talent fellow with the World Health Organization. So really part of that global social prescribing movement. So welcome to you, Caitlin.
Thank you so much, Helen. I just would like just quickly add to a few to that said. Are you hearing me?
Yeah, you're quite quiet, Caitlin. So if you could maybe speak into your microphone.
Can you hear me?
Yes, that's better.
Excellent. So, I mean, the concept of social prescribing, in a way, I think some of us have probably done one or two things before, but maybe those things were not formalized. And now, with the definition and the alliance that we're saying, now I think gradually social prescribing is taking shape and it's taking more specific definitions, engagements. And so, I mean, this reminds me of a particular patient we worked with in Nigeria in the psychiatric hospital, who was part of a music session. She was suicidal, and later on she encountered music in the hospital, and she found a voice. And after she left the hospital, she was recommended to volunteer to be part of our orchestra team in the community. And then, you know what? She joined the orchestra team that goes back to the same hospital where she was once a patient to give back to the same, same patient. Yeah. And you know what happened? Eventually, she went back to music school. Eventually,
wow.
She went back to music school. She graduated. Now she's designing webs. Now we're even thinking we're currently talking about hip hop culture for mental health in Nigeria because of the experience she has had. So these are possibilities. And when I saw the report, very interesting because I've seen it before now, and I was like, no African country was captured in that report. So for me, that's a red flag. And as someone like myself, I'm very global in my engagement. And if no single African country is captured, then there's a problem somewhere. And then, my hope is that I know in the month of May, when we are having our National Art and Health Week in partnership with WHO, one of the things we hope to achieve is to launch the social prescribing in Nigeria for the first time. And Nigeria will be the first African country that actually would have social prescribing. And already what we're doing now, we have activated students. There's a student group on the WhatsApp platform, a lot of them. Brilliant. So one of the things I hope to achieve out of this meeting today is to support from this particular group to help us to be able to activate this very well and to be able to do it very well. Thank you so much.
Thank you, Caitlin. And that you beautifully articulated that example there of those wider social determinants, that the health improvements that that lady achieved, but then getting back into giving back to the community, getting back into work, back into study, really encapsulates it. And thank you for your offer of integrating with the International Collaborative, and very best of luck. We can put a web link to those events you were talking about, can't we, Caitlin, in the chat, and welcome anybody who wants to attend those. So, well, thank you very much to Caitlin for a fantastic talk. We're going to move on now to thinking about older people and poverty. Over to you, Helen and Marie.
Very much. So hopefully that's Helen Chatterjee. Just give me a nod if that slides up okay.
That looks lovely.
Lovely. Thank you very much. So now for something completely different, but social prescribing. So as part of the International Evidence Collaborative and the academic partners, we were asked to look at the evidence around how social prescribing can support older people. And I'll just say it was older people to begin with. And I'm just going to take you through the evidence review we ended up doing, and Helen Seers is going to present the key findings there. But I wanted to give you an insight into our first stage process of working out what we were actually going to review, because you can't just review older people in a few weeks, and social prescribing, it's way too big. So there's a real process about trying to narrow down what we looked at, and we used a few different kind of mapping techniques. So that's what I'm going to just start off by showing you. So what aspect of older people did we want to first of all look at? So Some of you may know about the Social Prescribing Observatory, which has been set up by the RCGP, Oxford University, and the Referral Surveillance Centre. And what they do is, now that there are codes on the medical records for referring to social prescribing, you can actually track the number of referrals across England. You can break it down by age, region, levels of deprivation, ethnicity, gender, and put whatever combination you want in there. And there's also, this is the Social Needs Observatory. So these are, what are the referrals about? What are people being referred for? And there's 8 classifications here. There's mental health. I'm just going to bring a pointer up. So mental health, issues relating to long-term condition, substance misuse, abuse, employment, parenting, money, and housing. So again, there's probably nothing about justice in there. There's nothing about additional needs and disabilities, but this is a developing observatory. If you hover over each little spike here, you get a data point. So what I thought would be interesting was if I looked at the data for people over 65, and just had a look at, is there anything different to the mean that's happening? So the black line is, what's the referral for everybody of all ages? And then what's the referral rate for people over 65 in brown? Just eyeballing this, you could see there were a couple of areas where referrals were deviating away from the mean. So there were far more happening in this older population, and the long-term conditions were going up. That's quite hard to compare because these axes are all different scales. So, and anyone that does data analysis knows that actually what you've got to do is put it into similar scales. To make it far easier for us to really derive something practical, I took all the data points and looked for the range of averages. And these, I have to say, these are based on sometimes 300,000 people, 75,000 people. So this is a lot of data, and it gives you some confidence in the trends. I looked at the averages for the people that were over 65. So you've got a comparison here. And I like to color code stuff because it helps me visually make decisions. So I wondered, what is well above the average rate for adults for over 65? What was similar? What was like just above? You know, wasn't quite similar, wasn't well above. So we had just above. And is there anything that's less? So there were 2 areas that came out that were the average referral rate was well above. But the other thing I wanted to know is, where's the trend going? Is it well above and staying there? So actually there's nothing shifting in the last year, or is there anything where we think, gosh, that's really changed? And we know in the over 65s and slightly younger that the impact of the pandemic has been really severe. And we work with all sorts of healthcare professionals who are telling us the same thing, that when they get to see the older person, their condition is much worse than they anticipated. So there are 2 areas that actually caught my eye. One was managing a long-term condition, and we've seen declines increase in severity of frailty. There's a lot of cognitive decline, increase in dementia, all sorts of conditions. And the other one was around money. So that gave us a starting point. And I thought it's quite interesting. I did, in preparing these slides, go back and look at the trends to see what had happened. And I have to say we were bang on, that these 2 ones that are rising trends are still rising. And that was a learning point as well, because I think this is a good source of data to get some intelligence from. But we did some other stuff. I'm just going to summarize from the observatory data. There were differences in the referrals of rates for the long-term conditions. The rising trend was managing long-term conditions and money. If you looked at the most deprived and least deprived, there was a social gradient across all the areas of social needs. So the more deprived, the greater your need in every area. There was a gender impact in some areas, but not all of them. But the one that stood out was the difference for abuse. So women were 11 to 35 times more likely to be referred for domestic abuse compared to men in the last year. And being Asian, Black or mixed ethnicity increased your likelihood of a social referral for managing long-term condition, money and abuse. And the other thing is, if you were basically a white ethnicity, then you were not affected. You didn't have any increase in rates of referrals. So again, it really shows us that actually we have a long way to go in this country in dealing with inequalities. So we did a few other things to kind of think about what would be manageable for a rapid scoping review. We had a look at grey literature, we had a look at websites, we had a look at policies, like where were the policies going and what were they wanting? You know, could we be directed by that? We did some very crude searches for on our peer-reviewed databases, and we just looked over the last 3 years, because we know that whatever themes and whatever we knew about the needs of older people before the pandemic have kind of been blown out the water. So let's think about that. We then took this chart and we kind of mapped all these different areas, and it was just like, where do we think we can go? Where's green? Where's a yes for green? Is there data in that area? So where were we going to find the data? So we had to go ruling in topics, ruling out. We then did some really sort of more detailed searches, thinking about inclusion criteria. And we presented all of this back to Emily, who's with us, who's seconded into NASP from Independent Age. And we were like, okay, that's kind of all our intelligence. And we kind of chewed it over, I think it is fair to say. We had some really interesting discussions. And for Emily, it was about if they were going to put more social prescribing in place, where would it have the most impact? And Emily, you can kind of correct me later if you think haven't quite got there. But anyway, a moment of excitement was we did actually get to a stage and say, let's look at poverty, because we were finding there were lots of interrelated aspects of poverty that were coming out in the searches. So Helen, I'm going to hand over to you now, and you can just tell me when you want another slide.
Thank you, Marie. Great. So, and just at the outset, just to say this phase 2 work was done by me, Helen Seers, and Abby Saby. We did the kind of the spade work on this, guided by Marie and Emily and Helen Chatterjee. So we did a review essentially of the poverty related issues. We used rapid review methodology, so we didn't do a systematic review. We did a streamlined piece of work, which, you know, we can accelerate and get turned around in 5 weeks, so we can get a real snapshot of what's going on and be dynamic. We went to peer-reviewed literature and grey literature. We looked in, you know, the typical places: PubMed, CINAHL, PsycInfo, Google Scholar, and for grey literature we did All Cat Grey, which is a really good resource, which I recommend. And we also ResearchGate, we looked there, and we networked with all of the great experts that we have within this network that exists. We looked at recent literature because it's fair to say, as Marie said, about, you know, the pandemic affecting things and changing things. So we felt it was fair to go from 2019, acknowledging the recent impact of COVID-19. And we did have English language studies. We used really good software called Rayan, which is on this slide here, and if anyone's doing this sort of work, students out there or anyone else, I do think this is a good bit of collaborative software that allows the resources to be pooled, and we worked as a team to really do the search and then refine it down into the best studies that met our criteria. We went out to 22 studies. We also did an open call for grey literature within NASP, and this useful because, as you appreciate, the kind of area of research in this time is moving quite rapidly, and we wanted to know what was happening in terms of best practice out there, maybe interventions that are actually happening that may not yet be researched. So we did capture that for NASP as well. I'm not reporting that quite in these slides, though. I'm just going to tell you the findings overall. Next slide, please. So these were our main 5 areas of findings for how we mapped the research, as it were. looking at social prescribing, supporting older people in the context of poverty. So we have food insecurity, fuel poverty, financial management, digital inclusion, and social vulnerability. And I love it. I'm loving the way Marie's doing the pen for me at the same time. Thanks, Marie. So these were the five findings, but just to say, this is what the research showed us, and there may be more things out there, but this is what the research showed us. So firstly, just looking at each of the five, food insecurity, and that can be defined when, basically there's a lack of regular access to enough food to ensure health and normal life. And for older people, we did find there were a range of approaches out there supporting this: educational approaches, community food activities, and of course food bank provision. And this was all used in the context of social prescribing and community activities. We found that access to food banks and food from food banks was improved when obviously home delivery was available, because maybe it was difficult for older people to actually get to food banks and bring the food home. And also we found if food banks were co-located within other community organisations, that was good and helped. And food support provision can build community capacity. It can also, you have older people that go and work as volunteers, and they get a lot out of that. And it also enables older people to identify and connect with other community-based resources. So it's a win-win, essentially. So that's one of those topics. Next slide, please.
Oh, it's coming. Where is it
Thank
gone?
you.
There we are.
There we go. Fuel poverty, very topical, obviously. And our survey that we put out for the kind of wider work going on, we had a lot of interesting research in the area of fuel poverty, and this is emerging. And I bet you if we did this research sweep in a year's time, we'd find even more research in this area. Obviously, fuel poverty is where a household can't afford to keep adequately warm, and then this may lead to adverse effects in terms of ill health, mental health. We found interventions that improved heating systems, allowing improvements of mental health, well-being, less falls in older people, less arthritis symptoms, obviously, and less reported self-medicine use, which is interesting. And we did also find interventions that improved insulation in the house and ventilation, reducing things like mold, improving the heating system. And these interventions were shown to improve self-reported mental and physical health. We did find evidence that maybe some older people needed help with modern central heating systems, digital systems or thermostat control. So that was just something to be aware of in their findings. Next slide, please. Financial management. This was another topic that we found. Again, extremely topical in cost of living crisis. This is where sort of knowledge, confidence and skills in managing finances can make a big difference to people's well-being. We did find obviously issues around stigma and shame around income and finances for older people. This is something that the social prescribing community needs to be aware of, obviously. And as going back to Marie's slides about abuse, we did find older women were more likely to have financial problems, and this may be because they had more links to shame around disclosing this, or they may have been more exposed to coercive control or economic abuse. So these were really interesting findings, and I really would like to highlight this as one of the main findings here, so people be aware of. We did find interventions that, when the whole family were kind of included, allowed across the generations to help financial support and understand about, how to best deal with money. So we find they were useful interventions. And we did find things like tailored welfare rights advice did actually increase access to the best sort of maintained independence and ways forwards for older people. And furthermore, we just found that a coordination really between all different supporting agencies was needed for giving good financial advice that was trustworthy. Digital inclusion. So yeah, obviously digital inclusion is really important to consider. Older people may struggle to access Services, if they don't have smartphones, website, or the confidence to access it, can exclude people from accessing essential public services to support their health and well-being and financial well-being in a time when, the whole of society is becoming increasingly digitised. The interventions we found that could support older adults were at the kind of community level that increased that sort of self-efficacy and confidence around digital skills. And a byproduct of this was bringing people together and reducing loneliness in older people, which was good. There were examples of free digital skill courses and classes that were able to build up confidence for people and enable them to have better care journeys. And we did actually find really good examples of peer support networks, older people supporting other older people to build up their digital skills and confidence, which is really important. And then intergenerational programs, as in the kind of financial programs, going across and building up community-based skills. So really reducing barriers to digital inclusion and having the win-win of lessening loneliness. So next slide, please. And lastly, just from me, the last theme we found and explored is kind of an overarching theme of social vulnerability for older people. This is, the social circumstances people find themselves in, and they may be more vulnerable to poor health or social events, poverty. And older people are particularly at risk here. Things we've found in terms of interventions to help were home improvements, again, it's that improving warmth and helping with repairs and things like that. Accessing transport was very important as well, because older people find it tricky to get about. And last but not least, peer support, again, connecting up communities. So they were the themes. And now, if that's all right, I will hand over to Marie for some summary bits.
Thanks very much, Helen. And we looked across, so each of these 5 sections felt quite individual, and the links to the actual full report and briefing report will go in the chat if Sonia's not already put them in there. What we did find, what we did was barriers and enablers for each section, which are quite detailed. So if you are designing services to support older people, or you've already got some going and you want to see if there's anything else that's come out of the learning from the literature, and to say this was actually not just England, some of the studies were from I think Europe definitely, and I think Australia and maybe America. So there's some really good learning around the world. The 3, I would say, overarching barriers to supporting people living in poverty were the lack of disclosure from them due to stigma and embarrassment felt around financial problems. And I'll come back to the implications of that in a moment. So there's the hidden issues, which might take several sessions with the link worker to uncover. So there's something there about what's the expectation of how quickly you'll actually get to the root causes to be addressed. And another barrier was the accessibility of interventions, or lack of accessibility to interventions. And this goes back to this point that Cora made earlier, was there are groups of people that are, not really represented, and often because they find it harder to get to places or interact. So lack of transport infrastructure, but my goodness, how many times does that come up in social prescribing? And I don't know how we're going to crack it, but mental note, Charlotte, we need to work on this. The enablers that supported people living in poverty to actually get support and improve their well-being was a lot around developing peer training and supportive relationships. So I think that really helps the stigma aspect, that if you've got someone the similar age who gets where you're at and understands your culture and how you've been, how you've grown up and everything, it does help. And that particularly was helpful when you were trying to, with interventions where people were being taught, say, how to use technology, how to have, educational training. Offering information, advice and guidance and often at a multi-agency local coordination, so co-locations of justice services in health partnerships, and and put a food bank in there as well. And actually a person needed to get to one place only, and that was more manageable and more efficient. And trust through co-designed and co-produced services, so that they were meeting the needs of these people specifically. So just to finish up, very last slide, was really, again, we've got a little section on practical and policy implications in the review. And I suppose there were 5 things that we pulled out across everything. If you're going to do anything, a multidisciplinary and local coordinated approach is really needed, because there's a lot of organisations now supporting older people. And some of the studies went so far as to say employ a person who is that local place-based coordinator and help bring in these other learnings that we've got about maybe how you co-locate services as well. But somebody needs to be the coordinator. There's something about actively finding and engaging our older people who may be hiding their issues. So is that having different styles of conversations? Is that actually opening up aspects of conversations and knowing that if you're supporting an older person, you need to take responsibility for starting that aspect of conversation, even though it's a difficult conversation, because it may not actually be talked about otherwise. Developing that trust, and that kind of fits with this previous comment. Developing that trust was deemed at the heart of all interactions. So get that trust. Maybe it's going to take a little bit longer to develop, and that's probably going to help have these harder conversations. The co-designing the services with the people that are going to use them, and again, just going back to Cora's point, the service will work for the people as long as you know that you've heard from the people that need the services and how do they need them. And particularly some interesting data on actually making sure that older people have got some say in what the apps are and how they're designed. So if they're going to become more digitally enabled, at least do it in a way that works for them. And the use of peer volunteers and peer mentors came up in lots of the studies that we read and the reports, and just the value, as Helen said, it's a win-win. I think older people valued having people of similar ages to talk to, and those people that were the mentors were able to get something out of offering their time. So I'm going to stop there. I don't know if Emily wanted to come in and say anything. I know we're nearly out of time, but there we go.
Thanks very much, everybody. Emily, we've sort of run out of time for questions, but Emily, do you want to just come in and say something from Independent Age's perspective?
Yeah, thanks, Maureen. Thanks, Helen, and again a massive thanks to the team that worked on the review. It's really fantastic to see the findings. And yeah, I think this is going to be super helpful in terms of the work that we're doing at NASP around identifying where social prescribing can help to support older people experiencing poverty or financial hardship, and that's a key focus of Independent Age's strategy going forwards in terms of having that as a priority for their organisation. And so for us, this is going to lay the foundation for some pilot work that we're now embarking on around supporting older people experiencing poverty, and also crucially understanding the needs of older people who aren't yet accessing social prescribing. So again, sort of revisiting that theme that we've heard across the webinar around ensuring that we're being as inclusive and as accessible as possible. So yeah, just really exciting to kind of see opportunities to bring this work into action. And again, huge thanks for doing the review. It's great.
Brilliant. Thank you, Emily. And a huge thanks to our speakers today, Caitlin, Marie and Helen. And thank you to all of you for coming. And watch this space. Please join up to the Evidence Collaborative to find out about more webinars coming your way from April and May onwards. And thanks to you all for attending. Lovely to see you all. Bye, everybody. Ciao.